What we are here to talk about is what is an accountable care organization, and what, if anything, could that role play in a benefit strategy for an employer that you are discussing with. Here's the game plan that we're going to look at. The aims of an accountable care organization, the characteristics of the network, which is part of the organization, the attribution methodology, the clinical methodology and the performance, and rates, shared savings, risk, etc. These are the things that you should keep in mind if you are looking at an ACO as an option for an employer that you're consulting with, because we believe that unless all of these characteristics are in play with the accountable care organization that you are thinking about, you might have missed something. So let's start right here and just tell you just very briefly. MissionPoint is an accountable care organization. We were formed under the St. Thomas Health banner, if you're familiar with St. Thomas, which I hope you are. It's the oldest hospital organization in the Middle Tennessee area. 4 major facilities: St. Thomas West, St. Thomas Midtown, which used to be Baptist. I'm a Nashville native, so it's still hard for me to say Midtown. Middle Tennessee Medical Center in Rutherford County, which is now St. Thomas Rutherford, which is a huge organization growing. We have a community hospital in Hickman, and just recently put together a partnership with the Capella Community Hospitals in Middle Tennessee as well. So we are expanding even as we speak. St. Thomas, of course, is under the corporate parent of Ascension Health. Ascension Health, as you probably know, is the largest not-for-profit hospital organization across the U.S., some 80 plus hospitals in major and secondary markets. And before I forget, I will just mention that our MissionPoint ACO model has been tapped by Ascension to be their ACO model, and we are going to be expanding under Ascension into 5 other states within the next 12 to 18 months. Those agreements are in the process of being signed right now. That will be Illinois, Indiana, Florida, Alabama, Texas. Those are the ones that I'm aware of. And there will be obviously others to come. The reason being that Ascension, and I'll just give you just a very brief background about how MissionPoint developed. Ascension several years ago took a look at the healthcare delivery system, the fee-for-service system that we're all familiar with, that we've been using in our country for many, many years, and decided that healthcare delivery had to change. One of the reasons that they thought the time was right is because under the new healthcare law, ACOs can be formed by hospital organizations. Now, the term ACO, or Accountable Care Organization, is really a Medicare term, or was coined under the Medicare umbrella, I guess you'd say, I think around 2006. But basically, an ACO is designed to provide financial incentives for providers to improve quality, eliminate waste, and control the cost of health care. Under the ACO model, spending targets are set to reflect the expected cost of caring for patients. Quality of care targets are set, benchmarks if you want to call them that, which is what we do. When the ACO meets or exceeds the targets, the stakeholders share in the savings, and those stakeholders are the providers and the employers, the population group itself. So understanding what that definition means, I guess everybody understands it's basically pay for performance, I guess is the way you can look at it if you're a sports person. Employers that are thinking about something new, how can I get my insurance costs under control? When we say progressive employers, we're talking at employers that are ripe for change. Those that are saying, I'm not satisfied with the way things are, the trends keep going up, every year it's more and more and more, I keep pushing more and more onto my employees, is there something better? Those are the employers that are out there looking and talking to their brokers and saying, what else is there? There are several things that they're looking at. They're looking at new payment models. They're contracting directly with hospitals, physicians, and ACOs. They're looking for incentives that they can use to put into part of their mix, and they're looking for performance-based payments. If you'll stop to digest this for just a second. This is very, very important. There's a big state of change going on. I was in McMinnville on Tuesday to meet with a group of employers who got together under their Warren McMinnville Chamber of Commerce. And they called on River Park Hospital, which is a Capella hospital, one of our partners, and they said, we need some help. Can we just contract directly with you to lower our cost of services? Most of these people are with Blue Cross. Small employers, 20 employees up to several hundred. And that area is growing. More and more industry is moving in. A lot of it has to do with support for the automobile industry, of course, that's exploding in Tennessee. And they said, we just can't handle these increases. The hospital, fortunately, called us and they said, there's a great model over here. Maybe you need to consider something like this. So I dropped by and visited with several of them and presented our MissionPoint model. Some of them were familiar with what an accountable care organization is, some weren't. But it gave them something to consider. But they had already realized that we need to do something about the cost of care when an event happens. What they weren't really thinking about is, can we do something before the event happens? And of course, that's one of the things that an ACO is designed to do. But there are employers out there looking for alternatives, looking for new ideas. So if you encounter one of those, here's some things that you might consider. I don't know what that group of business owners really plans to do. They haven't decided on their structure yet. If they're going to operate under the Chamber of Commerce, we might be able to put together a package for them as business owners. They might decide to form a captive. There are several things that they're considering as far as their structure is concerned. But we're very interested in talking to them to see what the opportunities might develop. So moving on, the aims of an ACO should be to improve the health status of our community. If we're not improving the health status, then we're not doing our job right. We should be reducing healthcare costs, obviously. We should be improving the patient experience, and there is room for improvement, believe me. Enriching the lives of the caregivers is something that people are a little curious about. When MissionPoint was formed just about 3 years ago, as a matter of fact, we count things in dog years at MissionPoint because things have progressed so rapidly. When they sat down, the wiser heads, to decide how to put this model together, they interviewed some 300 or so doctors, employers, employees, obviously patients, other community leaders, to find out not only what was wrong with healthcare, but if they could design it on their own, what would they do? How would it look for them? Overwhelmingly from the physicians, we got that they're not happy with the way they have to practice these days. They're not happy with the paperwork. They're not happy with the government regulations. They're not happy about the time that they are not spending with their sickest patients, because they have to see so many patients during the course of a day that they might have, and as you well know, maybe 5 or 10 minutes for you when they really need 30. Just to keep the lights on, they're having to increase the number of patients that are run through their practices. So they're not happy. Many of them are deciding to retire earlier than they might otherwise. I was reading a blog just the other day about physicians that are saying, I'm done. It's just too hard. It's not the way I intended to practice. Many of them are choosing to join a hospital organization as a hospital physician. Many of them are doing that concierge situation that you've probably heard or read about. They're just trying to get a handle on how they can practice and have a better quality of life. So we knew when we were putting together this model that we had to have the buy-in from the doctors. If you didn't, then we knew it was not going to work the way it was designed to work. So let's talk about the network. There are two very important parts of what an ACO is designed to do. The first is to present a network of providers. Those providers consist of your primary care physicians, which is a huge part of what we advocate, but you've got to have your specialists, you've got to have your ancillary services, and all the pieces that need to come together to provide a complete continuum of care, what we call an integrated network. So the components of a network, the key considerations for that should be, as I mentioned, a good mix. Now, the primary care is what we consider the backbone. You can call it the family doctor, whatever nomenclature you want to use. You may already be familiar with the statistic that about 33% of people in the U.S. do not have a primary care affiliation. That's really not good. Because what that means is they are making the decisions about how to interact with the healthcare system, and they may not be making the best decisions, as we all know. Dr. Mike Schatzline, the CEO of St. Thomas, I love the quote. He says, everybody needs a quarterback on their healthcare team, and that's what the primary care physician is designed to do. So we strongly advocate that people need a primary care. We try to work with people to help them find the best relationship possible. It's not required for members that are part of our network to have a PCP, but we strongly push them in that direction because we know what a difference it will make. The specialties, everything. Obviously, St. Thomas Heart is a big part of our network, but many of the physicians that are part of our network are not affiliated with the hospital. Well, most of them practice at all of the hospitals, naturally. The subspecialties could be anything. It could be your labs, your long-term care facilities, any other ancillary delivery method for care. Our medical director, Dr. Asher, had a meeting the other night with a group of pain management specialists and chiropractors. Whatever we feel that we need to plug in the holes, I guess, to deliver quality care, whatever that needs to be and wherever it needs to be, that is an important part of what an ACO network should be. The geography is very important. What service area does that ACO manage, in other words? And a lot of it has to do with not only where people live, but where they work and where they travel back and forth, as we all know, and that's a big part of Middle Tennessee, as we're probably aware. The benefit design, we believe that an ACO should work together with the benefit design that employer already has, that they feel is working for them. Maybe they decide that it needs some tweaking, but a good ACO model will work within the constraints of the benefit design that your employer needs. A big part, as Justin mentioned, is the data. The collaboration, the governance of that data, and how that data is managed, the connection points between the various providers in the network, the kinds of data that is transmitted and shared, and how that is analyzed. Yes, sir?
What tools would you use to determine who gets in the ACO?
That's a very good question. There is a governance board that if a physician wants to be part of our network, applies to, and they look at all kinds of quality metrics. Someone is not, they have to be voted in, pretty much. We do. There are metrics. Pardon? I would say in conjunction with a number of factors. It's not the MissionPoint scorecard, I guess you could say. It's metrics and quality measures that have been judged to be the best in order to make a judgment about whether this practice or this doctor is a good fit. You realize that they have to agree to certain terms to be part of the network. Okay, they're going to agree to payments at a certain level. They're going to agree that they have to meet quality measures, and they're going to be judged on that. And the shared savings piece, which I'll get to in a few minutes, depends on whether or not they meet those measures. And there are a number of those, depending on what their particular practice is and the kinds of patients that they see. And there are also incentives that are built into the model to incentivize them to deliver care a little bit differently as well. So it's not automatic. I will tell you that our network now consists of about 1,700 physicians and service providers of all kinds. That is considerably larger than most ACO models have. The average ACO is around 400 to 500. And when our model was developed, I'm told that they really didn't expect it to be more than about 400 or 500, 600 maybe at the most. It's exploded because physicians want to be part of the network for one reason. Another is that we see that we need to fill whatever gaps are necessary. But physicians are now calling us and say, I'd like to be part of your network. And of course they have to be vetted naturally. There are a number of criteria that have to be evaluated. And there have been occasions where the vote has been no. They've reapplied a year later. It may or may not change, who knows. Wiser heads deal with that than me. I'm in business development, I don't do that part. This is what we call a heat map, which gives you a representation of where our network currently resides. And actually, this is not quite up to date. I think this is about 3 months old. But as you can see, we take a huge swath right through Middle Tennessee. So the geography of an ACO is important because you need to have physicians and providers where people want them to be. The facilities have to be available as far as the hospitals and the ERs. The labs have to be available. The endpoints have to be convenient for people to be able to use them, because the whole point of being part of an ACO is to use that narrower network to help control costs. So if you need to fill in the gaps, as we have from time to time, we're always adding providers. And you can see that we go all the way up into Kentucky. And the group that I met with in McMinnville yesterday, on Tuesday, if they decide to bring MissionPoint in to work with them, we'll be looking at what do we need to put together in this area that we don't already have to help bolster that network for them. So the geography, of course, is very important. Yes?
How do you compare outside of the Middle Tennessee footprint?
Diane, will you hold on 1 second? You
Certainly.
mind repeating it?
Sure. Yeah, the question is about care outside of your Middle Tennessee footprint, how you all handle that for people traveling or dependents outside of the area, out of network. Do you have a wrap type network that you're using for that?
That is obviously a question for the benefit design. We work with self-funded employers right now, and the majority of people that we work with, their populations are within this Middle Tennessee footprint, as you can see. If the design can be loaded as a tier, and I'll get to that in just a moment, that solves the problems. So if I could hold your question for just a few minutes, if you don't mind. But that is an excellent question, and it does have to do with how the network is loaded, and obviously the benefit design as well. This is an example of some of the partners that we have in our network. As you can see, we've got long-term care, hospice, and these are just some examples. There's hundreds more, obviously. And as I mentioned, the Capella hospitals, community hospitals in Middle Tennessee are now part of our network as well. An ACO needs to have as many of those services covered as possible. As you pointed out, you want to be able to help control those costs, but you also want the continuum of care available for the members that are using the network. So if you can provide those services and keep those services integrated within your network, you're going to get the best data, you're also going to get the best rates and the best usage naturally. Partnerships with physicians. It needs to run the gamut, whatever the population needs. Maybe a formulary pharmacy, people that are proficient in asthma. Diabetes obviously is a huge one here in our obesity belt here. Behavioral health, which we discovered is now a huge part of what we do in our clinical management. I think we kind of underestimated some of the psychosocial needs of populations out there these days. Drug addiction being one that was mentioned when I was in McMinnville the other day, is a huge problem in their area. Depression is a huge part of people that are sick. particularly those people that have chronic conditions that need to be managed. If you can't manage the depression, then you don't have as good a result in managing the disease state itself. So there could be family issues at home. A lot of things that we've uncovered as our health partners, our trained nurses, work with members to help us figure out that there needed to be a whole path to deal with those behavioral situations as well. And this is just an example of some of the types of physician partnerships that we feel are very important in an ACO network. So if there's something missing in an ACO that you could be looking at, you want to be sure that leadership is aware and they need to be trying to fix that gap, whatever that might be. The whole idea is to provide, I guess you could consider maybe a circle if you're a visual person like I am, and we look at it as a complete continuum of care. That is what an ACO is designed to do, is to close up the gaps, connect the dots, make the transitions, the hands-off that are missing in the fee-for-service model that we have now. So let's look at the methodology itself. And to speaking to your point here, as you mentioned earlier, one of the things that the clinical management, now I'm going to move over to the clinical management piece, which is the second piece, is important, is that you really should, an ACO should manage all of the members, covered members of an employer, not just those that happen to be using the network. And the reason there's several, as you can probably imagine. One of the reasons, naturally, is because you get the best data from the entire population and their dependents rather than just a few here or there. An employer generally wants to know what's happening with their entire population, and they need to know what's happening to dependents. That could be one of the highest cost drivers right there is the dependent population. So unless you're managing clinically all of the members of their group, you're missing. Naturally, you want to also try to drive those members to use that narrow network, which is the high quality, low cost network, which is part of the ACO to begin with. So to speak to your point, what we believe the best way to approach that is to layer, if you will, the narrow network on top of the current benefit design. So that would be more of a pyramid design, I guess you could say, because that's going to be your lower cost. By helping to manage clinically all the members of that employer population, you have a better chance of driving people to the narrower network to help control the costs and obviously to be able to use the clinical management tools that we have in place. Then your other network, your in-network, would be your second layer, and then of course your out-of-network. This is the design that we believe is the most advantageous to most employers. Obviously, those self-funded companies that work with their TPAs would have to decide, is that TPA able to load it this way? This is what we feel is the great way to solve the problem that you just mentioned and give people the choices that they need and help people to be better consumers, naturally. They still have the options to go into a wrap network or out of network, and they can freely move around within it, and this is what we recommend. As you can see on the second part of the slide, we develop pathways, transition plans, we monitor the performance, patient activation wellness services, the IT structure, all of this is part of the back end, I guess you could say, of what that member will experience. We believe it starts with that medical home, that little house right there, that primary care, surrounded by the specialists, and obviously the technology that marries the two pieces of this together.
Have you found a good way to, because you were talking a little bit about benefits with tiering of networks and things, to make this concept work where high deductible health plans are involved?
That's a very good question, and I'm probably not the best person to speak to that. We've talked to a couple of employers so far that have that type of model. We're still discussing with them how that could look. I think everybody's kind of scratching their heads over that one just a little bit. As you probably are aware, employers, many of them made the decision to go to that model as a way to control costs. It pushes more and more of that decision-making process onto the consumer, and many consumers are not prepared to handle that. In our view, and maybe I'm speaking personally for myself at this point, I will say that if the deductible is so high, even with the health savings account, many people don't get the services that they need because they know a good chunk of it's coming right out of their pocket right away. Maybe they don't know how to manage that HSA effectively, or maybe it just takes too long to save up for that procedure, so they delay getting the care that they might need on the preventive side. I see a few smiles in the back. What we know is that that can be very detrimental to certain chronic disease states and other people, which is unfortunate. I don't know if there's going to be a backlash on that, to tell you the truth. I think a lot of it has to do with the type of population. My son's 27. When he graduated from college, went into a great IT job. Young population, as you can probably imagine, high deductible HSAs from the get-go. He never knew anything else. After he got out from under mom's umbrella, that's what he had to deal with. So he learned to manage that from the very beginning, okay? Somebody that's 55, they may not have experienced that until just the last few years. And that's a hard transition for a lot of consumers to make. So we are very mindful of that and are looking at ways that we might be able to work with companies that have that. So that's still under discussion, I guess you could say. I wish I had a better answer for you. But there are populations out there that are still offering, several different programs or choices to their employees now, because they know that making that change one fell swoop is pretty tough for some employees and members to take. I was thinking about a large municipality that still has the traditional plan in place. They have an HSA with a high deductible and another type of plan. And right now, apparently, they're about one-third. But I think they plan eventually to move more and more people into that high deductible category. But I will tell you this, they don't have a lot of data on their claims, and they really don't know the state of their employee population well enough yet. So I suggest that they need more information about what's been happening with their population before they make some big changes.
But if you have better cost structure under the, if you have a better cost structure under this, would you not think under a health savings account plan where the member's going to pay the first portion, they would see a lower cost under this than, say, a provider that's not within the ACO?
That's the goal, obviously, and a lot of that has to do with messaging and education to help people understand that they would be better off under that model. Naturally, that's the whole goal. Naturally, it takes a lot of consumer education, I think.
I definitely think there's a place. I think the push and pull with it is with a high deductible health plan, I'm going to call it capitation or risk fee, whatever you want to call it, that you're paying for some care that may not be given under a high deductible health plan. So I think that's been the challenge in some of these that we've kind of looked at is, what do you do for those people and how do you reimburse the ACO for the people that are in the high deductible health plan, and what makes sense from that standpoint.
Right, and what makes sense, yes, that's a very good point, what makes sense. We're all still learning, we're all still trying to figure it out, and I would not want to be one of those people that was trying to make those decisions on the employer side, I can tell you. So moving on. As I pointed out, the data analytics, the information that we gather is critical. I'll stop here and mention that we are partners with the advisory board. We use their Milliman data analytics tool, their Crimson tool, and the Milliman data that they have compiled over a number of years across the United States from millions of data points from large employers, small employers, et cetera, is what informs us when we sit down with a potential client to talk about how to create a benchmark about what a normal would look like so that they could see how well they are meeting that norm or how far outside it they are and what the goals should be. So the data analytics, the technology is a huge part of what an ACO needs to be involved in. Now let's talk about the clinical side. This is the part that I think makes the whole difference. And I'm going to speak specifically to the MissionPoint model because we believe we've got the secret sauce that makes all of this work. The clinical methodology, of course, is how you work with those patients and how you get them to a better state. So the member, of course, we hope is going to have a PCP. They're going to be part of that medical home. And hopefully they're going to use that network regardless of what they might need. There is going to be a per member per month. That PPM is obviously part of that ACO model. There is going to be a shared savings pool, and that shared savings is created against that benchmark that I just mentioned. That means that, let's say, for example, you have a client that's spending $100,000 a month on their claims costs, just in round numbers. On average, that's been their history in the past. Once we create that benchmark, which we all agree on, that we're going to bounce their performance against, let's say that we're able to cut their costs down to $90,000 a month. So there is a savings of $10,000 per month. After a 15-month run out, we will then look at what that shared savings pool has accumulated to be. Part of that shared savings pool goes back to those providers who provided the care for the members of the network, and that speaks to the metrics that they have to meet, the quality that they have to show, because they have to show that they are meeting the needs of that member population and they're trying to get them healthier naturally. So they stand to not only, I guess they are capped, but to have on the other side a portion of that shared savings. And a portion of that stays with the employer because they are the ones, of course, obviously absorbing some of that risk as well. Hope that makes sense because that's what makes an accountable care organization work. There has to be savings. There has to be someone standing at the front and saying, I'm going to partner with you and I'm going to help you create those savings, and we're going to share those savings because we're going to be accountable for the health of this population, and we're going to do whatever it takes to keep these people healthier and to lower your costs. Now, we as MissionPoint, we're taking a risk because we're saying we're going to create savings for you. If we are not able to create those savings, there's nothing to share. As the employer, they wouldn't get a piece of the pie to keep, and those providers themselves would not be sharing in that savings. And they know that going in and becoming part of our network, that this is the goal, is to have that shared savings on the other side. Hope that makes sense because that is really a very, very important piece of what makes an ACO work. Now, moving down into this part here, the health partners, this is what we call our secret sauce. Our care teams, if you want to call it, right now are divided into 3 categories. They're probably going to be subdivided even more as we learn more and more about working with members. We have a team that's called ambulatory, one that's transition, and one that is behavioral health. The transition team are those trained nurses that interact with a member after they've hit a facility. If they've been an inpatient at one of the hospitals, if they've made an ER visit. It's more than just the case management that you might be familiar with some of the TPAs. This goes far beyond anything that you have ever been aware or have experienced. Basically, the mantra is whatever it takes. Whatever it takes to get that person to a healthier state. We could work with somebody for a year if necessary to get them to a better place. I think I've got a couple of samples of an article that was in the Tennessean recently about one of our Medicare members that we worked with for a year. But she's now off her meds and has a better quality of life and exercises at the Y 3 times a week. It took a year to get her to a better place, but that's what it took and that's what we did. Now I'll stop here and mention we do service a group of Medicare patients, more than 30,000 right now. That's through MSSP, of course. We just took on a Medicaid population from Amerigroup. That probably will expand as well. And then, of course, our employer groups is another bucket. So we really have 3 buckets of members that we work with. Our trained nurses run the gamut of skill sets. We have people that are out of the ER, from pediatricians' offices, from long-term care facilities, from nursing facilities, behavioral health, as I mentioned, people who work with drug addiction, pretty much anything that you can think of that is necessary. One thing we are learning is that wide variety of skill sets is extremely important. We have people that focus on wellness, people that focus on lifestyle coaching, pretty much whatever it takes, and the teams expand as we speak. The transitional team, as I said, meets with somebody after they come out of the hospital. In fact, the nurse actually pays a visit to the hospital while they're still there, and fills in the gaps about knowledge, what that family needs to know about care, whatever they need that they're not perhaps maybe getting from the doctor or the nurse or whatever, just to be sure they understand about their care. And then we follow up with them at home the next day after they're discharged, and for the next 30 days if necessary, whatever it takes. Even if we have to make a home visit, we will do that if it's called for. Information that needs to be sent out to them. We'll help them make an appointment at the doctor if they don't have transportation to get their prescriptions filled. If they have questions about their prescriptions, maybe they don't even understand what this medication is for. We've even been able to uncover situations where a medication was really not working well with another medication that had already been prescribed, and we would call and work with the doctor to get something else changed out. We even found a few cases of people being prescribed things that they were actually allergic to. It's not a fault of the doctor, it's just those things happen. But having a health partner being able to uncover that before they had to make the trip to the ER saved everybody a lot of money and a better patient experience, obviously. And then our behavioral health team works with a lot of the organizations here in the Nashville area, like the WISE, for example, and other organizations, to help people stay connected within their community, whatever they need culturally, whatever they need environmentally, within the family. We stand to fill in those gaps and help point them where they need to go or counsel with them directly. So this gives you an example of a little bit about what our workflow could look like, and I did have some newsletters in the back, and this graphic happens to be on the back of that newsletter, as a matter of fact. But this is just a generalized workflow of how it starts most of the time, whether it's the hospital or the ER visit. There are 3 ways, basically, that a member of MissionPoint could interact with one of our health partners. They could be admitted to one of the facilities, an ER visit or an inpatient visit, and then we follow up with them directly. They could be referred to us by one of the physicians in our network. I have a patient that needs more help than I can give. I'd like for you to follow this diabetic patient of mine, and we will do that. They can also self-refer. So a member of the network that says, I'd just like to have some help with nutrition. I want to lose a few pounds before my daughter's wedding. Can you help me out? I've tried several ways to quit smoking. Nothing's worked for me. I need some coaching help. Can you do that for me? Whatever it might be, we can help that person, and all they have to do is call our member services and they say, I need a health partner. So they are connected as much as they want to be connected, and we hope that they are taking advantage of that, and that's hopefully where the human resources people will help affect that. This is what Justin was talking about as far as the data analytics are concerned. This gives you a particular deep dive into a patient, and we can build a particular profile on everyone, because what it does is to help us figure out how we need to interact with that particular member, particularly those that have multiple morbidities and chronic conditions, and those care paths are designed for that person. We have traditional care paths about how to work with someone with COPD or that sort of thing, but obviously we stand to manipulate those whenever necessary. Sometimes we have worked with as many as 3 different health partners from 3 different categories of skills in order to help somebody get to a better place. So it's whatever it takes, basically. But it starts with the information, the claims information, the past history. We know the medications they're on, how many visits they've made to the doctor. It's interesting. We did a CPRM analysis for a client here in the Nashville area about a year ago, and discovered this one particular person had seen 25 different doctors over the course of a year. I'm going to assume he didn't have a primary care. And the multiple medications that he was on was extraordinary. Who knows how many extra tests or lab results that he'd probably gotten as a result of all those doctor's visits. And I can probably tell you he wasn't any better off than he would have been if he'd had a primary care and things had been a lot more controlled. So these are the kinds of things that we find out from the data analytics, obviously, which helps inform us about where we need to go for that particular patient. As far as performance is concerned, this is just an example of the kinds of information that we can gather from an employer group once we are able to analyze their data. Typically, we would love to have 3 years of claims data to examine with our Crimson tool. We don't always get that. We can do it with a year's worth of claims data. But what that tells us for that employer population gives us some ideas about what we can do to affect some change. We can immediately identify what we call the high-cost drivers, the easy fixes, I guess you could say, those that we know that we can affect almost immediately. And then it also gives us some indications about what we can affect longer term, making a plan for 2 or 3 years down the road. And this is what helps us to also inform us about what I call the pre-conditions or the pre-pre conditions, those that are just sitting out there waiting to happen 3 or 5 years from now. That is where the true cost of controlling costs really lies. As you well know, having a narrow network that's high quality and lower cost is going to translate to savings when there is an event, but what can you do to prevent the events or to keep those events lower cost events rather than, say, the kidney transplant? So identifying what those preconditions are and the ways that you can interact with that population in a more effective way now maybe will prevent some of those diabetic patients later on. That is obviously the goal, and that's one of the roles that the data analytics plays for us. This gives you an actual example of this is the St. Thomas Health population. These are St. Thomas members and their dependents, and what we were able to accomplish for them after the first year. And you can see that trend coming down, and that's the whole idea. We were able to save them 12% in their first year of managing their population. This gives you an example of some improved outcomes. For example, avoidable admissions and readmissions coming down. As we all know, that really translates to savings, and the hospital systems are very engaged in controlling this cost, as we all know. Emergency department visits. This is a huge part of what we do with the data analytics, is finding out when people are going to the ER and what they're doing when they get there and what is unavoidable. And this really translates to savings for most any employer population. And as you can imagine, that 33% of people that don't have a primary care, many of them are using the ER to substitute for that, and that's a very expensive substitution. I saw a graphic just the other day that the average PCP visit is around $150 or so, but that ER visit is close to $600 for the same situation. So why spend almost 5.5 times more when you could take care of it at that lower level? So that's a lot of what we do is to find those indications. This also was from the St. Thomas population. Healthcare workers are no better than anyone else. We're not any healthier than the average population, unfortunately. I wish I could say that we are. Here's another example of how the network can work for you to help you lower costs on the utilization, being in the right place at the right time. Where to get the MRI, where to get the CT scan, where to have the labs done. If you have them done within the network and at, say, the office as opposed to the hospital facility, the costs are going to come down. And that's another function of a very robust network as well, to be sure that you can handle all of those interventions that are necessary. And you can see how the decrease came down almost 23% for MRIs, CTs by almost 11%. So shifting the location of the utilization was a 17% cost decrease right here. Yes?
You might get to this, Diane, but when we're looking at, for example, the hospital outpatient MRIs, as consultants, if we're sitting with a large hospital system or a multiple state employer, I assume that with the Crimson tool, we can carve that data and peel back the layer to identify a certain location and to measure that data at that specific location.
Absolutely. That's a huge part of what the data analytics can do. It can really do a deep dive, particularly for that employer that has multi-locations. Was speaking to someone about that the other day. We were preparing a big proposal to do health screenings for an organization that's in about 10 states, I think. And obviously they want to see what the population looks like by geography. And we certainly can do that. So yes, thank you for asking that question. So here's some key considerations when you are considering an ACO model. Am I going to pay more or less than I did before? Do I get to share in any savings? You should. And am I going to be able to exchange some of that savings for some of the risks that I'm currently experiencing? And we do take on a portion of that risk. The providers take on a portion of that risk. The analytics and the innovation that comes out of that, as Justin pointed out, is huge. Looking at that dashboard again that we just looked at before, you can see that if you look across the top, it says the overall PMPM and what that benchmark, if you can read that underneath, the overall PMPM is 325. The benchmark should be 169 per person. So there's huge room for improvement there that we've identified. And let me just mention about the benchmark. When we look at all this analytics and these data points, that benchmark is agreed upon between MissionPoint and the employer. We don't arbitrarily set that because we have to come to an agreement about what that reasonably should be. So we'll look at those claims. If there's an anomaly one year, maybe there were 3 transplants or, huge other emergency brain surgery or whatever that really spiked, we'll take those out. That is not what we consider the norm. And of course, anything that hits your stop loss is going to come out anyway. So we would agree on what that benchmark is going to look like, and any ACO should do that very same thing. They should not arbitrarily assign that to a client. We can create those benchmarks based on the overall, the medical itself, or the drug, and many other benchmarks as well. These are the 3 key ones as well. And as you can see, they've got some room for improvement there. ER utilization, as I mentioned, is one that we can affect very, very quickly, and this is an example of some data that came from a CPRM we did for a client. And as you can see, there's a lot of ER usage during the middle of the week. You would expect to see some on the weekends, but why would there be some during the middle of the week? I don't know if the story I'm about to tell you speaks to this particular one, but I'll tell you how we were able to solve this particular problem for a group of pediatric patients. You're probably aware that childhood asthma is a big problem in the state of Tennessee. And one of the things that we do, one of the things that our providers are required to do, is to sit on a committee that looks at best practices for their particular category. I think there's somewhere between 17 and 18 standing committees that Dr. Asher, our medical director, supervises. And all of our providers are required to give 2 to 3 or 4 hours a month unpaid to sit on a committee that pertains to their particular specialty. So we have a group of pediatricians that specifically look at childhood asthma because that's a big problem. They looked at some data last year that they were a little concerned about, and it had to do with the ER usage. They saw some big spikes with these children coming into the ER during the middle of the week, and they were very concerned about that, naturally. So they did some deeper digging into the data, because we have it, and they even talked to some of the parents of the patients. And what they discovered was a very easy fix, actually. The inhaler that is prescribed as an emergency for anyone that has asthma, comes with the inhaler. But for children, they also get a prescription for a little piece of tubing that attaches to the inhaler, and that helps to deliver the right measured amount of medication at the appropriate time. I was not aware of this. My kids never had asthma, and I wasn't aware of this. But apparently the accepted way to write the prescriptions is to write two different prescriptions, one for the inhaler and one for the little piece of tubing. Well, unfortunately, many parents were buying the inhaler. It's not cheap, and they were deciding, well, maybe I just won't get that right now. Okay. So little Johnny would go to school, he'd get excited during recess or whatever, he'd reach for his inhaler, and it wasn't delivering the right kind of a medication. He couldn't breathe. The school nurse would call the parent. They'd come pick him up at school, and they'd take him to the ER. Oh, Johnny's having an event. This is really serious. And it was simply a matter that the inhaler wasn't delivering the right kind of medication. So our physicians looked at this and said, well, we can change this very easily. We'll just change the way we write the prescription. We'll write this prescription together for both pieces, maybe increase the price $1 or $2. They look to MissionPoint and say, can you pick up the tab on the rest? Which obviously we did, so we took a little small hit on that. But it translates to huge savings to keep those kids out of the ER when they really didn't need to be there. So we made that change with our own best practices simply by having a bunch of our physicians sitting around saying, how can we fix this? This is a small problem, but it's translating to big dollars, a bad patient experience, obviously. What can we do? Now, I do challenge any TPA out there to come up with that quick a solution, that fast, that easily. It probably wouldn't happen that way. They'd be looking at data claims for a year before they decided that maybe there was something that needs to change. And I'm not speaking against any TPA out there. I'm simply saying this is how things get done with an accountable care organization, because we're right on top of it. So I hope that example makes sense. I like that example because it's so easy. It just makes so much sense. In this particular case with this employer, we saw that 33% of those ER visits were actually treatable by a PCP. So if they had made the decision to call their primary care physician and go in, 33% of them could have been taken care of right there. And obviously we know that's a much cheaper fix than making a trip to the ER. Non-emergent means that there was no follow-up at all. They were not admitted to a hospital for any reason. There was no other further treatment or anything that needed to come from that ER visit. And of course, 3.5% of them were totally unavoidable anyway. I do have a story about, actually, she's one of our nurses at St. Thomas who suffers from migraines, as many people do. She did not have a PCP of her own. She was admitted to the ER because of a severe migraine that had gone on for several days. They gave her a shot. She was able to get back to normal, but obviously our health partner followed up with her the following day after the visit to the ER to see, how are you feeling? Did the immunization work, the shot work for you? Well, let me counsel you. You really didn't need to do this through the ER. But since you don't have a PCP, and we know that they don't because it's in their patient profile, let me help you find someone that's going to meet your needs, and let's look for a longer term solution for your migraines rather than just hitting the ER once in a while when it gets to be too unbearable for a shot. Then that was the natural course of events, naturally. I don't think it occurred to her that maybe that wasn't a good way to manage her migraines, but on our side, we knew longer term she needed a longer term solution that was going to be lower cost and keep her out of the ER naturally, which of course she did. Member registries, this is increasingly going to become important to the physician as far as the the EHR, the health partner data that we receive, health risk assessments. Big data is driving a lot of decisions these days, as you probably know, and this is just another way that we can segment populations and look at people in different ways. One thing that I mentioned to Justin earlier, a good part of what the data should do is to help predict. And if you've got the right data and it's analyzed in the right way, it should help inform you about what's coming down the pike a year or 2 years from now. But it also can help you predict plan design and what that plan design might affect as far as costs are concerned. And so with the Crimson tool, we can take, say, your co-pays and your deductibles, tweak that. What difference would it make if we made that ER visit $200 instead of $150 or whatnot? How could that change your design? And the predictions on this are extremely important, I think, for you to look at. We at MissionPoint offer a lot of different types of services, and I believe an ACO, a good ACO should do that as well. It should offer the small survey like a health risk assessment or a biometric screening to give you a quick look at a certain point in time of what your population looks like. It should also support in a number of different ways, different lifestyle coaching, stress management, for example, healthy eating, whatever it is that population needs to help get them to a better place. But the huge part, the engagement part, of course, is the narrow network and the clinical management that pulls all of that together. And that, of course, is the big piece. I don't know if I mentioned that we also build and manage on-site clinics. And we just recently opened one for Aegis Labs, just right over here off Mainstream Drive. And in fact, our corporate office is right over here on Mainstream, just across from the Titans bubble. So if you ever have a chance to drop in and visit with us, we'd love to invite you over. But we do build and manage on-site clinics for a large retailer across the country. We're in 3 states with them right now and have 3 that we're going to be open by the end of the year as well. So that's another expertise that we can bring to large employers or groups of employers in a particular area. There is a plan to do what we call a multi-employer model in some areas where 2 or 3 employers could group together and have a clinic for their population if they're obviously in a fairly contained geography. Some of the innovation that we've put together, and I don't know how innovative it is because everybody uses the internet these days, but if you're looking for a specialist or a primary care, you can go online and put in the metrics that you're looking for and find what's going to mean the most to you, those that are taking MissionPoint members, those that maybe have Saturday hours, if you're looking for that, because they are incentivized to do that. They get a little extra piece of the pie if they offer Saturday hours, if they do medication reviews, and if they send emails to their patients and other things like that, obviously new delivery models. But of course, you can always call our member services and they'll help you find the PCP. This is a picture of one of our telehealth units. We are partners with Cisco, and we have been very fortunate to have that partnership with them and using and developing new tools to meet the needs of underserved populations in outlying communities or places where they don't have a specialist on a particular way. That happens to be one of our St. Thomas heart physicians on that huge monitor right there that's doing a heart consult with that patient, and I'm thinking that she's in Tullahoma, if I'm correct. Many of these are set up in physicians' offices, and they make appointments with the telehealth people, just like they would if they drove into St. Thomas or whatever, and they can consult. The patients love it. Obviously, it solves a transportation issue for many of them. You can't see it, but there is a nurse in the background that's actually taking tests and feeding the data in to the doctor so he can see it real time. And we've had great success. I think there are about 45 of these endpoints throughout the Middle Tennessee area and growing all the time. So we're very proud of our association with Cisco. And that wraps it up. I hope all of that made sense, and I hope it gave you some things to think about. If you do have some questions, I'll take a couple of those. I know you're probably about ready to move on with the rest of your day, but
Any questions? All right, well, please join me in thanking Diane for her time today.
well, thanks again for having us. We appreciate it very
Yes,
much.
yes.